Welcome to The Explainer. We are going to bypass the basic summaries today, guys, and dive straight into the deep end. We are meticulously breaking down the clinical criteria and the exact pharmacology of sleep pathology. We're looking at how these really complex disorders are diagnosed and treated in a true clinical setting.
Okay, let's dive into this. Our structured clinical taxonomy today covers a syllabus-style roadmap. First, the physiology of normal sleep. 2, insomnia, diagnosis, and treatment. 3, hypersomnolence and narcolepsy's pathology. 4, parasomnias ranging from slow wave to REM. And finally, number 5, restless leg syndrome management.
Section 1, Physiology of Normal Sleep, Establishing the Baseline. Now, before we can even begin to examine the pathology, we absolutely must establish the exact physiological baseline of the human sleep-wake cycle. So normal sleep cycles alternate every 70 to 120 minutes. We kick things off with stage 1 and REM, marked by theta waves, which takes up just a tiny 5% of our total sleep time. Then, we drop down into stage 2 and REM. This one dominates at 45% of the night, featuring those distinct sleep spindles and K complexes. After that, we hit stage 3 NREM, which is our deep sleep, complete with those slow, robust delta waves. And finally, we enter REM sleep, accounting for about 25% of the night. It's genuinely fascinating, right? Because REM presents with the exact EEG of a fully awake, aroused person, but it's combined with complete muscle atonia, literally paralyzing you, alongside wild fluctuations in your respiratory and cardiac rates. Understanding this exact architecture is absolutely crucial because it's precisely where the subsequent pathologies we're going to talk about deviate.
Section 2, Insomnia, Diagnosis and Treatment, Criteria and Interventions. We're transitioning now to our first major pathology, and we need to look at insomnia not just as having trouble sleeping, but as a very specific set of clinical criteria.
When you look at the epidemiology data, true clinical insomnia has a prevalence of 6 to 10%. That actually makes it the single most prevalent of all the sleep-wake disorders we'll be covering today.
But to be officially diagnosed, patients have to meet these very strict DSM-5 criteria. It involves difficulty initiating sleep, maintaining it, or experiencing those frustrating early morning awakenings. But pay close attention to the chronological markers here. This has to occur at least 3 days a week, and it has to last for at least 3 months. This distinction is critical, guys. It separates just having a few stressful nights at work from a true chronic pathological condition. And importantly, this happens despite having an adequate opportunity to sleep.
Let's move to and see how this builds into a highly systematic pharmacological treatment hierarchy. Clinicians don't just jump straight to heavy sedatives. Step 1 is always non-invasive, rigorous sleep hygiene and cognitive behavioral therapy specifically for insomnia, known as CBTI. If that fails, Step 2 introduces short-term benzodiazepines or melatonin. Step 3 escalates to Z-drugs. And finally, for those highly refractory cases where nothing else works, Step 4 involves the off-label use of antidepressants like Mirtazap, or even low-dose antipsychotics like Quetiapine.
Section 3, Hypersomnolence and Narcolepsy Pathology, Arousal Deficits. We're shifting our focus now to disorders of excessive sleepiness, setting up a really rigorous look at the underlying neurochemical deficits.
Now, hypersomnolence is distinctly different from simply needing a little more sleep on the weekend. The DSM-5 diagnostic markers require excessive sleepiness despite getting at least 7 hours of sleep. Patients experience prolonged, totally non-restorative sleep lasting over 9 hours, and they have immense difficulty waking up. Just like insomnia, this has to happen more than 3 times a week for over 3 months. What's incredibly interesting from an etiological standpoint is that this persistent condition, which often has this insidious onset between ages 15 and 25, can actually be driven by viral infections, head trauma, or even genetic autosomal dominant inheritance.
Now, a highly specific and well-known variant of hypersomnolence is narcolepsy, affecting roughly 1 in 2,000 persons. This condition is fundamentally driven by a fascinating neurochemical deficit. It's characterized by the autoimmune loss of specific hypothalamic cells that produce hypocretin. Think of hypocretin as a critical neurotransmitter that regulates your arousal. This specific deficiency is a primary diagnostic marker for the disease.
And this brilliantly illustrates another fascinating, though often distressing, clinical feature that accompanies narcolepsy: severe hallucinations. We clinically differentiate these into 2 very specific types based entirely on timing. Hypnagogic hallucinations occur exactly when the patient is transitioning into sleep. Conversely, hypnopompic hallucinations happen when they are transitioning out of sleep. Because narcolepsy presents with such distinct and varied symptoms, clinicians have to map out highly targeted pharmacological agents. If the target is excessive daytime sleepiness, the first-line therapy is modafinil, eventually moving to amphetamines as a second line. But what about cataplexy? That's a sudden bilateral loss of muscle tone, often triggered by something as simple as laughter, experienced by 70% of narcoleptics. For that, the target completely shifts. First-line therapy becomes sodium oxybate, which modulates GABA-A receptors, with antidepressants like TCAs, SSRIs, or SNRIs acting as second-line drugs to suppress REM.
Section 4. Parasomnias. Slow wave to REM. Abnormal sleep behaviors. Here we establish that these clinical deviations are categorized entirely by the specific sleep phase in which they occur.
Let's analyze the non-REM or NREM parasomnias. Both sleepwalking and sleep terrors originate in that deep, slow-wave NREM sleep we talked about earlier. Sleepwalking episodes are brief, usually under 10 minutes, where the patient is extremely difficult to arouse and will be super confused with complete amnesia of the whole event if awakened. Sleep terrors, on the other hand, involve sudden partial arousals with frantic motor activity occurring in the first third of the night, also leaving no memory the next morning. What's really striking here is the shared physiological origin and risk factors. There is a massive 80% familial risk factor for sleepwalking. This ties these conditions deeply to genetic and physiological predispositions, rather than just purely psychological stress.
Now, contrast those NRM disorders with nightmare disorder. This pathology occurs during the last one-third of sleep because it's deeply rooted in the REM phase. Unlike sleep terrors where the patient wakes up totally confused, an individual waking from nightmare disorder rapidly becomes alert and oriented. Clinically, if this is associated with PTSD, doctors utilize a highly specific alpha-1 blocker called prazosin, right alongside targeted psychological interventions like image rehearsal therapy.
Staying in the REM phase, we encounter a severe physiological failure, REM sleep behavior disorder. Remember our baseline? REM sleep is supposed to feature complete muscle atonia. Well, in this disorder, that atonia fails. Because the brain is highly active but the body is no longer paralyzed, patients will vocalize or physically enact complex, often really violent dreams. We're talking literal limb-jerking, running, or punching in bed.
So the crucial point is, this isn't just about disrupted sleep. Diagnosing this parasomnia is absolutely vital because it so often serves as a precursor, an early indicator for severe neurodegenerative disorders like Parkinson's disease, multiple system atrophy, and dementia with Lewy bodies. Catching this early is absolutely crucial for any neurodegenerative intervention. Section 5. Restless leg syndrome management, diagnosis, and phased treatment. This is our final clinical category, and it has a very unique symptom profile.
Restless leg syndrome, or RLS, carries a 2 to 7% prevalence, affecting females more than males. The defining feature here is an overwhelming desire to move the legs just to relieve uncomfortable sensations, and this strictly worsens at rest and at night. From a diagnostic standpoint, we explicitly look at risk factors. It is strongly associated with iron deficiency, and paradoxically, it can be heavily triggered by the specific drug classes meant to help other conditions. We're talking antidepressants, antipsychotics, and dopamine-blocking agents. Because of this very specific etiology, clinicians walk through an exact hierarchical standard of care. Step 1 has to address the underlying basics, iron replacement and behavioral strategies. If those symptoms persist, Step 2 utilizes dopamine agonists like pramipexole or ropinirole or benzodiazepines. Step 3 introduces alpha-2 delta ligands such as gabapentin or pregabalin. And finally, for the most highly refractory cases that fail all those previous interventions, Step 4 allows for the careful escalation to low-potency opioids.
We thoroughly unpacked the precise clinical criteria, the exact brainwave stages, and the escalating pharmacology behind everything from insomnia to REM sleep behavior disorder. As we wrap up this explainer, I want to leave you with a final provocative thought. How will our evolving grasp of these precise neurochemical deficits and distinct sleep phases continue to refine the way we pharmacologically treat these complex disorders? It's a truly fascinating frontier in medicine. Thank you so much for engaging with this detailed academic breakdown today. See you next time.